Why don't you come and sit a few lines before, because otherwise I have to stretch my neck in the wrong place. It's very good that you came in front.
Okay.
Yeah. Thank you.
Okay, let us start. Actually, this is really, I'd like to thank really Professor Henk Schmidt for responding to our invitation to conduct this in a short notice for the participants as well as for him. But he always responds to our request. He never say no, and this is what we really very familiar with this, and would like to thank him very much for this. And I'm sorry that really few people are here, but we have also other group online, which is a good number online. And this is also going to be recorded. It will be distributed for all faculty later. And Professor Henk Schmidt, I think you are very familiar with him. He's the top medical educator, the top researcher, according to academic medicine and according to Google Scholar Index. And he really published a lot of work on clinical reasoning, on problem-based learning, on patient safety, and why doctors make errors, which is really very important research for patient safety and also for medical education. And today is going to talk really about the recent advances in clinical reasoning research, which really will help also in informing our reform here and the way forward in medical education. Welcome, Hank.
Thank you very much, Mohi. Mohi was my former PhD student in the 90s. And I'm happy to be here because of him, partly, and to talk to you. Indeed, I'm an educational researcher, but I'm not somebody who focuses only on research. I like to teach. I like to develop courses, and I've done that a lot in my life. But today it will be on research into how you teach clinical reasoning. And you should realize, or of course you know in a way, that diagnosis is really the most important instrument that a doctor has to restore health or prevent disease. But diagnosis is a fragile instrument. It is sensitive to all kinds of outside influences that makes it a very difficult task. For instance, context plays a very important role. Assume that you are a doctor and you are a family doctor, you are in your consulting room, and a person comes in complaining about pain in the extremities and high fever and coughing, and outside a flu epidemic is going on. Then your conclusion might be very quickly, oh, this is another example of flu. But then the gentleman tells you that he has been in Africa, in the Congo last week. And then suddenly the perspective changes. So the contextual influence on diagnosis is really very big. There are many examples of how context influences diagnostic reasoning. And if you're not sensitive to that context, you will make mistakes. Another problem of diagnosis is that disease presents itself in different ways in different patients. So patients talk about pain in the chest often in different ways. And that makes it very difficult to arrive at some sort of a diagnosis. And also because there is an enormous overlap between diseases in terms of the signs and symptoms that you would find. In fact, people have only a few ways to express their pain and disease and feeling unwell, whereas there are more than 1,000 different diseases that may play a role. So this is perhaps the reason that every year in the United States, 250,000 people die because of medical mistakes. Medical mistakes are the third source of dying in the US behind heart problems and cancer. 250,000. You know, if you extrapolate to the United Arab Emirates, it means that in this country, 8,000 people die of medical mistakes. And the majority of these mistakes are diagnostic mistakes, as researchers have found out. They are the result of misdiagnosing a disease, and therefore people get into trouble. And if in this country 8,000 people die, it will mean that the disease problems, the health problems of many more people are affected by wrong diagnosis. So the question is then, how can we reduce diagnostic error? And the answer is, actually is the only answer that we can have as a medical college, is training. And there some problems arise. You know, in conventional medical education, the training of clinical reasoning is largely left to the rotations and the residency. And in these situations, training in clinical reasoning is more or less learning by doing, seeing patients and trying to come up with the right diagnosis and management. And there is certainly variable quality of supervision and feedback. Some supervisors take time, they help you, they give you feedback, they discuss with you the cases. Some don't, or do that hastily because they are busy. And a major problem is also the nature of the patient population in hospitals. You know, if you have an academic teaching hospital, the people that are there are so sick that they only represent the 2% of the total population of patients you could see. They are very sick, and their diseases are limited in nature. If you have a you have to okay. In other cases, in other teaching hospital, non-academic, there are often two types of problems, namely that it has been shown that almost half of the students sees almost no more than half of the diseases they should have seen in order to sufficiently learn. And one of my PhD students kept a logbook together with students in one of our peripheral hospitals in the Netherlands of the kind of diseases they saw. First, they spent half time while on the ward sitting, doing nothing. And the other half, they saw only a very limited number of different diseases, mainly diseases of aging, diabetes, heart problems, and not other diseases. So the rotations and even perhaps the residency in academic teaching hospitals are not the best places to learn clinical reasoning. And medical schools have noticed this and have begun to provide teaching clinical reasoning within the pre-med or the preclinical curriculum. Now let me show you some stuff from a review that I did together with my colleague Sylvia Marmeje. Sylvia Marmeje is Sylvia Marmeje is my co-worker. She is a physician coming from Brazil. She did a PhD with me, like Professor Moi. And she was so mesmerized by clinical reasoning that she stayed in the Netherlands. And we have been working for 15 years together in the Department of Psychology and in the Institute of Medical Education Research in Rotterdam. And she and I have done a review of the different approaches to diagnostic reasoning. Now let me show you some of the results. It's not very important, but it gives you a view of the differences that emerge when academics, clinicians try to teach clinical reasonings to students. First, there is this difference in the format in which students, there is a difference in the format in which these cases are presented. And there is a certain preference for what I call here the serial queue approach, which is the patient data are presented sequentially, and the students have to think and ask themselves, what question would I ask next, given this finding? The whole case approach is essentially that you present the whole case to the students with all the information that is there. And then there is a difference in the purpose of the teaching approach. Some of the approaches are very much knowledge-oriented, either looking for causal mechanisms of disease, or knowledge-oriented, looking for distinctions between lookalike diseases, so knowledge-oriented, or process-oriented. Now, let me tell you a little bit about the process-oriented approaches. What teachers do when they focus on the clinical reasoning process, essentially, they try to teach students how clinicians think. So the focus would be on hypothetical deduction. The focus will be on Bayes' theorem. It would be on decision trees. It will be on biases. You know, what kind of biases will happen when you are reasoning clinically, and how can you debias? Now, these approaches have been quite extensive. Actually, the majority of the papers that we found was focusing on process, but they have in common that they have no effect on clinical reasoning. So these students do not become better in clinical reasoning compared with how good they were before they entered the course. There's no effect of process orientation on improving clinical reasoning. Now, let's concentrate on the other side, on knowledge-oriented approach. You wanted to ask something? Okay. First, I have to tell you a little bit, but I assume that you already know, but about the two modes of thought in clinical reasoning, namely direct recognition of the disease versus reflection. Essentially, it means that if you see a patient, then immediately a possible diagnosis pops up, even when you have only limited information. That is interesting. That's efficient. It's of course also a little bit dangerous, but this recognition response develops under experience. You know, the more experience you have, the more patients you have seen, the easier this response becomes. And then reflection means, you know, you think about the case. You are analytically busy with the case. So it's assumed that these two brain processes, two cognitive processes, are separate, even that they refer to different brain areas. For instance, no, let me first briefly say what distinguishes them. And so system one, this is it's one of the modes of thought is essentially pattern recognition. You see a patient and you know. It's automatic. You cannot escape from it. It comes to you even if you don't want to. It's inflexible. It doesn't require effort. It requires no attention. It's fast, and it is assumed that it is activated in the limbic system. And then system two, this is the thoughtful analysis of symptoms. It's deliberate, it's flexible, it's effortful. You have to take time and think and rethink. It requires conscious attention. It's slow, and it's activated in the prefrontal cortex. And so this idea that these two processes are situated in the in different parts of the brain is an idea that is really very prevalent in the literature. So system 1 originates here in the limbic system, and the system 2, conscious reasoning, is situated in the prefrontal cortex. Now, there are different ideas of what is good and what is bad. You know, there is a researcher, Daniel Kahneman. He is a Nobel Prize winner because he does a lot of research in decision making. And he wrote a book called Thinking Fast and Slow. It's a bestseller. And his point, you recognize the two systems, system 1 and system 2 in the title. And he believes that thinking fast is dangerous. You should avoid thinking fast. You should, if you can, you should engage in slow reasoning, in conscious, effortful reasoning. And then there is another researcher. He's a great friend of mine, also a medical educator and a medical researcher, Jeffrey Norman. He's a former nuclear physicist, but in the 60s there was no work for him in Canada, and therefore he decided to join a medical school where he was developed as an epidemiologist and number cruncher. And he says, you know, pattern recognition characterizes the expert. The real expert sees no problem because, you know, he immediately knows. If you do not immediately know, if you have to engage in effortful reflection, then you are already in trouble. And there is, in fact, research that supports both point of view. I myself, I have shown that if you give easy problems to physicians and you force them to think about it, their first diagnosis is much better than the second one. And you confuse them when you force them to reflect. But if the problem is very difficult, then the reasoning process that you force upon them leads to improvement. But the point is, of course, you don't know whether a problem is easy or difficult. So that is not very helpful. But there is something in there for both of them. Now, when students start engaging in clinical reasoning, of course, they use system 2 because they don't have the experience of system 1. They don't know, they haven't seen enough patients, and therefore the starting point is always reasoning, effortful and slow. And I'm now going to with you to another presentation in which we have shown, I think for the first time, that there is something true with regard to the difference between these two systems, and you can observe them already in medical students. This is a neurologically or a neuroscientifically oriented study that I have completed together with a colleague of mine in Singapore, who is also at the Erasmus University, Jerome Rothgans. So this is a series of slides that he has made. Now it becomes, oh yeah, okay, yeah, okay. So the task that we set second-year students at LKC Medicine in Singapore was to diagnose X-rays. And they had no prior experience with diagnosing X-rays. But we want to teach them how to diagnose and arrive at the right diagnosis. So here are the X-rays. And of course, dual process theory is the guiding framework. This is system 1 versus system 2, two competing brain systems, the kind of difference between the two. And normally, the way we study diagnosis is looking at how much time people need to solve the problem and of course, diagnostic accuracy. And you can imagine that the higher the diagnostic accuracy and the shorter the time, it looks like system 1. If people very shortly come up with a diagnosis, system 1. If they need more time, system 2. Now, let me show you what we have done. Students received 8 cases. They had never seen them before, but for each of these cases, there was an explanation. So there were, you see them here, there were arrows pointing at certain parts of the screen, and there were 8 cases, and you see the titles of the different diagnoses that were used. And so students received the picture, they received the diagnosis, bulla, and they received the description of what bulla would look like. Yeah, and that for 8 diseases. And then there was a learning phase. In this learning phase, they had to diagnose 4 cases, half of the cases they had seen once. And they would not see 4 other cases anymore. Yeah, this is the experimental condition. And they saw the 4 cases that they are supposed to learn several times. You know, they saw them so long that they would not make a mistake in terms of the right diagnosis. Yeah. And then there was a test phase. They received the same 8 cases. They had to diagnose them. And of course, we looked at how much time they would need and the accuracy of diagnosis. And of course, and we did something else, which makes it special. Namely, we measured their brain activity with FNIRS. FNIRS. This is the experimental design. FNIRS is a way to measure the oxygenation of the prefrontal cortex. And oxygenation suggests that that part of the brain is active. Yeah. And so our students all received this cap, and the measurement was done on them. Now, let me show you the results. Now, the behavioral measures, of course, are no surprise here. On the left, there is the diagnostic accuracy score for cases that they had trained for, that they had seen several times, had to diagnose, they received feedback. Their score was 90%, whereas for the cases that they did not see after the first time, it was 30%. And response time, of course, the other way around. Cases seen much faster than cases not seen. Now, here you see the results of the measurement of oxygenation in the prefrontal cortex. You can ignore the picture here. This is a description of what works. It's even a little bit of a movie, but the point is this. When people see cases for which they were not trained, you see that the oxygenation increases during test. Whereas if they had seen the cases before, there is no growth in oxygenation, showing that whatever is happening is happening here in the prefrontal cortex, but is happening somewhere else in the brain. Of course, to study it full, you need an fMRI. Then you could also study the hippocampus and the limbic system as a whole. But this is the first demonstration of the fact that there are 2 processes going on, and that indeed, when you are forced to think, oxygenation starts. Now, we have published this in, I believe, in medical education in 2018. And now we are going back to the other one. And so this was only a demonstration of the difference between system 2 and system 1. And you see that students start with system 2, and then move under experience, under training to system 1, which is okay, which is right. Now, now I'm going to confront you with a procedure that Sylvia and I have developed, and not only for students, but also for residents. The procedure is called deliberate reflection. And so we force students to deliberately reflect upon a case that they see, and we hope that they learn by doing that. Now, let me show you. Now, you have seen this case before at the beginning, so I don't have to show it anymore. This is a case that we would present to students, and then we would start with deliberate reflection. First, what we do is read the case and provide an initial best diagnostic hypothesis. So, you know, whatever comes up with you, this is your diagnostic hypothesis. And then we ask them, write now down which signs and symptoms in the case, which findings in the case support your diagnostic hypothesis. And write them down. And we call that confirmation. So you have a hypothesis and you confirm, you look for evidence that confirms your hypothesis. But then we ask, which findings do not support your diagnostic hypothesis? List them. And this is falsification. Now you are looking at signs and symptoms, like findings that do not support whatever came up. And then the third one would be which findings should have been there if your diagnostic hypothesis is correct and are not, and list them again. This is looking for omissions. And you have this idea, you have confirmatory information, but maybe the confirmatory information is not correct. And then we ask, do you now have an alternative hypothesis? If so, do it again. You know, take the new hypothesis, confirmatory, falsification, omission. And then, you know, if you think you're ready, what is your final diagnosis here? Now, here you see an example of how this looks like. Huh? So you had this case, and the first diagnosis that came to mind was the asthma diagnosis. And then the person wrote down findings that speak in favor, findings that speak against, and findings that were expected to be present if asthma was the diagnosis and were not. Then this person came up with two alternative after each other, but I showed them immediately. He said maybe COPD is an alternative, and then we said, okay, now indicate what supports it, what is against it, and what is missing here. And the same for pulmonary embolism. And then we asked them to rank their diagnostic hypothesis, and this person decided that asthma was the best one. And perhaps it was pulmonary embolism or COPD. Now, what happens here is that people are forced to compare findings with regard to different diseases. They are busy to compare and contrast. And while doing this, they are thinking, they are reasoning. And the issue is then, does it help? I mean, it looks quite, you know, what you could do, but does it make a difference? Now, we have done a study, actually several studies in the meantime, but this is a study. And so the issues here, not only, you know, does deliberate reflection leads to new hypothesis, but does deliberate reflection to better diagnosis 1 week later with similar or not similar cases. Now, this is somewhat difficult to read. The study was done, in fact, in Belo Horizonte in Brazil. And the students had a learning, by the way, the students were as good as students in Western Europe and students here, so no difference. They received 2 cases of acute myocardial infarction, 2 different cases. they received 2 cholelithiasis cases. And they received 3 filler cases. These cases were unrelated to the experiment, but they were meant to hide the purpose of the experiment. And for each of these cases, they had to do deliberate reflection. And then 1 week later, there was a diagnostic test. They received 1 new case of acute myocardial infarction. They received a lookalike, but different disease, stable angina pectoris, and a disease that is somewhat further away in terms of signs and symptoms, the reflux case. And they received a new version of cholelithiasis, acute viral hepatitis and hemolytic anemia, and then again, filler cases. And then we looked in how well are they now doing on these cases 1 week later. Now this is the learning phase. Now what you see here, I should tell you that there were in fact 3 groups, namely a group that simply was asked, give us a diagnosis. There was a group that was asked, give us a differential diagnosis. And there was a group of students that had to go through the deliberate reflection exercise. Now, what you see here is, what you see here is that the differential diagnosis at learning did somewhat better than the other 2. I don't think it was significant, but it was doing somewhat better. Now, let's look at the results 1 week later. We are going to look first at the performance of the 3 groups in previously learned cases. So we are talking about cholelithiasis and the myocard. Now, here you see that there is a clear difference between the 3 conditions. The deliberate reflection group is doing significantly better than the other 2 groups. This is of course interesting. It's great. It means that you have an instrument to teach students diagnostic reasoning. You have an instrument that might help them if you do it often enough with enough cases and so on. You don't have to do a test every week later, but you know now that if you do this in the classroom with students, possibly with small groups of students who work together, then they learn from the deliberate reflection exercise and become better clinical reasoners. Now, sorry?
How the group of differential, what the questions?
They were simply, they were presented with these 8 cases upon learning and asked, give us a differential diagnosis, at least 3 diagnoses. And that was it. Yeah. Now, interestingly, we also looked at the cases that were studied, cholelithiasis and myocard, and also the lookalikes together. And what you see here is that these students were also better, the deliberate reflection significantly better in doing that, in responding to that. And then we also looked at non-previously studied cases, only the adjacent diseases, the lookalike disease, and again, you find an effect. So, if you have a little bit of advanced students, because students should be in a situation in which they already have seen cases, and you begin to use this, and you use it often, before they enter clinical practice, before they enter the rotations, I'm sure that they will become better clinicians simply because they have seen a lot of cases in the course of their training and have thought of a lot of the cases during their training. So this is not useful if you do it once every year. Then it's, but if it is part of the curriculum, if in every block, in every course, there will be, at the end, for instance, half a day of training with deliberate reflection, then that would make a difference. Now, I'm looking at the clock. I still have a third example, more for undergraduate students, but I would suggest that we stop here and refer to some of the articles that you will find if you type in the name of Mameje or me, and you will find our studies, you find reviews of our studies, you find also the description of the deliberate reflection approach. So, you know, I'm now open to some questions, Dr. Awad. If there are any. I mean, it's possible that I was...
Please use the mic, Doctor.
Question, Prof. What about script concordance test for medical or clinical reasoning compared to the just study that you mentioned? Any comparison between two methods and anything better than the other?
You know, the script concordance test was based on earlier work from my group on illness scripts. And a colleague, a Canadian colleague, then came up with a script concordance test based on these ideas. But the problem of the script concordance test is that it is, like the others, focusing on process. You know, do you make the right steps, and do you make them at the right moment? So I don't know of any study that has shown that the script concordance test, when taken by students, would help them become better clinical reasoners at a later stage. But I believe that the situation is still open, you know, can be discussed still. But the script concordance test sounds more like a findings management system rather than something that you could use for teaching. But, you know, if you are fond of it, try it. Any other questions?
Thank you, Prof. Henk. For those who are attending on Zoom, if you have any question, please raise your hand, or you can write in the Q&A or the chat area. We can raise your query and Prof. Henk can respond. Oh, smart. I know it. I just make on the mic, please. Turn up there. It's not working.
Okay, now it's working. Sorry, I messed up. I am interested in the early clinical exposure, actually. Wasn't sure because, I mean, most of it is dependent on observation. So if you're actually in the clinic and that's a workplace-based, you know, like environment or context, would you think that, you know, early clinical exposure will actually have an effect, in your opinion, to develop, you know, clinical reasoning? If you're
Clear that deliberate reflection would not work in the workplace because it's too busy and too floating, and you have to make decisions quickly. So it's typically an instrument to be used in the first 4 years of medical school. There it can be very useful. And it needs to be done in a situation in which students already have some knowledge of the relevant diseases. Otherwise, it won't work anyway. An alternative to, let's say, diagnostic reasoning through deliberate reflection is what is called here learning through self-explanation. So there are a number of Canadian colleagues who present cases to students and then say to these students, please think aloud, explaining why these signs and symptoms emerge in terms of the underlying pathophysiological processes. So they focus extensively on the biomedical or the biological basis of disease. Where do all these signs and symptoms come from? And so that is more basic and can be done in the first year when students are really working on basic sciences, biomedical sciences, with simple clinical problems. this kind of approach, the deliberate reflection approach, is typically something that a little bit more advanced students do.
Deliberative, your opinion,
Um,
the best time, I mean.
Yeah, I mean, I'm always thinking of year 1 and 2 as learning by explanation, and in year 3 and 4 more deliberate reflection. But I'm surprised how good students can be in a very short time, because you saw what we did with the X-rays, the studies of lung X-rays with students. These second-year students had a limited amount of anatomy, and then were confronted, and within 30 minutes, they changed from being a novice to an expert using System 1. So maybe it works as soon as there is sufficient disease knowledge.
Prof. Salah, please. Unmute, Prof. Salah.
Okay.
Yeah.
Sorry, I have a cold. Can you hear me?
Yes, I can hear you.
Thank you, Professor. I just wanted to make comments and one question. Sorry about my voice. I partly lost my voice. The successful patient students or doctors encounter depend on so many important clinical skills, and the doctors or in training or students need to be trained appropriately, and one of them obviously is clinical reasoning, which is a buzzword nowadays. But if I can go through them very quickly, I mean, in order for this encounter to be successful, you need to take a systematic, professional, comprehensive history based on the patient complaint. These are fact gathering, and they need a specific training. And then you need to know how to examine the patient systematically, appropriately, professionally, to be able to detect physical signs if they're present, and not to detect physical signs when they're not present. And only then you come to formulate a differential diagnosis. That's when clinical reason comes in. And obviously, with that, and with these facts being accurate, you will be able to make a sensible the differential diagnosis or management plan based on the patient complaint or even a relative of a carer. These are very important skills. Beyond clinical reasonings, obviously, there are some other skills which include two important ones: maintaining the patient welfare, safety, dignity, and comfort, and also being able to address in a sensible, respectful, knowledgeable manner patient concerns. All the 4 or 5 or 7 skills I mentioned, they need specific, targeted, professional, and reliable training. But clinical reasons comes part of it. But I see people sometimes see clinical reasoning overshadowing all these important training areas. And this is what we see in clinical practice now. A doctor sees the patient, listens to the complaint in a very unstructured manner, and then order tests. And depending on those tests, they formulate. And that made people have great difficulty in maintaining these important skills. I just wondered what's your thoughts on those comments?
I entirely agree with you. Of course, what you describe is, let's say, the advanced stage of learning to reason clinically. I would say that in one way I don't agree with you, because what you describe is, let's say, first get the data in, first the findings, then the diagnosis. This is not how the brain works. You know, when a physician sees a patient, and based on very limited knowledge, all kinds of ideas of what is going on already pop into his mind. That does not mean that you should not be systematic. I entirely agree with you, and thoughtful, and communicative. But what you describe is a complex of a large number of skills that students eventually have to master. The physical examination skill, the interpretation of lab results, the meaning of what the patients tell them. What I have presented here is really the beginning of this process, where you take a lot of the load away by simply presenting a full case. So they don't have to gather the data. They don't have to collect the findings, because the findings are there. What they need to do then is to make sense out of the findings. And therefore, this approach is useful, in particular in the early years. But of course, if they enter the clinical phase and the clinical rotations, of course, they need to do what you just so vividly described.
Thank you.
Thank you. Any questions? Yes, Prof.
Okay, thank you very much, Professor Henk, for this enlightening presentation. I'd like also to ask about other methods on clinical reasoning. Is there any other studies, for example, on concept mapping, thinking aloud, both statistical, deductive comparison between those?
Most attempts at teaching student clinical reasoning have been enormously disappointing. And first, in some cases, because there is a wrong emphasis on the process of clinical reasoning rather than on the contents of clinical reasoning. And second, because the field is new. There are not many researchers doing work. Our Canadian colleagues with learning through self-explanation use the think aloud method, ask students to think aloud while being presented with cases. Here you see it. A 70-year-old woman presents with progressive jaundice. The patient presents a gradual yellow discoloration of her skin over 3 weeks with nausea. She noticed that her urine has become dark. And then the student says, yeah, this may be because there is more bilirubin in the blood and in the urine. It reminds me of hemolysis. And then the tutor says, what is hemolysis? And then the students continue to think aloud. Now, what they found was in a study comparing people who had to think aloud versus people who had to come up with a differential diagnosis, that for familiar cases, that didn't make much of a difference. But if the cases were rather new, but in the same category, there was an effect of thinking aloud. And apart from that, there is very little. In fact, in reviews of others on how to teach clinical reasoning, mostly the studies that I'm talking about, or have talked about now here, are mentioned as the only ones that up till now work. So it means that there's a lot of space for new ideas and new types of studies.
Yeah.
Teaching clinical.
No. No. Yeah.
Yeah, actually, he's trying to teach the students as expert. He present case and then ask students to come out with differential or diagnosis, even from the start of the discussion. And then he develop again and go to systematically on others. So what do you think of this approach?
He explained it to us at length, and I thought it was very interesting. And such an approach should be studied. I must make one thing clear. What you have seen now are studies in which students are treated as individuals, and they are not supposed to talk with others. They have to do it all alone, because these are experiments. We try to keep the procedures as precise as possible. But in real life medical education, it turns out to be very good to use these methods in small groups, where students, while talking about cases, learn from each other as well. And this is perhaps one of the strengths of Professor Arif's approach, but you have to study whether it really works. So I'm not advocating individual students to confront with lots of cases and then have them do deliberate reflection. I believe in a small group approach, and that might work.
Yeah. I have a question, Prof. Sorry. Yeah, actually, but since we are thinking that eventually at the end, when the students, they become residents or become specialists, they will tend to use system 1, which is realizing or recognition rather than the one with reflection. So, I mean, how we can, and we cannot control this. So my question is, what skills we need to teach our students in order to allow them to be more flexible and to choose the right way and the right time to move among both systems? I mean, we should concentrate on the safety of the patient, how much the case is critical, or so this is my question, because ultimately, if we are still loading them and giving them the guidelines, how to follow the reflection and look at the case step by step and getting and the omission and all these things. But eventually, when they will start to practice, they will just jump immediately to use system 1. So this is my question. I'm not questioning the approach itself. I'm questioning the way how we can do this, how we can convey this message to the students in a way that allow them to use it effectively, both systems. Let us say we can utilize the best of both systems.
Yeah, we tried this with with beginning residents. We taught them the difference between system 1 and system 2 and how these processes worked. And then we looked at an experimental group, whether they would use more reflection, thinking.
Yeah.
Nothing.
Nothing.
No, because, this is the way the brain works. You cannot escape from it.
Yes. Something
comes up and you test this idea by some reflection and then perhaps another idea, but that's it.
Yes.
What in my view helps is when you have come to a conclusion, when you are almost certain that this is the right diagnosis, have a second look at the material. Have a second look, a critical look. Ask yourself, would there not be any other alternative here? Would there not be an alternative?
Yes.
That would not take much time because you already have all the data and a diagnosis. But that is the only thing I cannot come up with. But, what I want to stress, that's why I began with the story of the 250 deaths in the United States and the 8,000 deaths here, is that we simply do not do enough. We should have a clinical reasoning curriculum. And of course, basic sciences and clinical science play an enormous important role because clinical reasoning is knowledge-based.
Yeah.
But we should give the students exercise. We should give them practice in diagnostic reasoning as often as possible. And I have no doubt that that is the better approach to less dying because of medical mistakes than trying to convince people that they perhaps should deal with their cases differently. Because, a resident coming out of a program like the program here, where we are going to do this. Lots of clinical reasoning in the pre-clinical, pre-medical years, hopefully. When such a student comes out of the rotations, I think he has more knowledge and better knowledge and more relevant knowledge and leading to fewer mistakes.
Yeah. Because, doctor, reaching for the decisions is usually based on the knowledge, and the knowledge is sometimes coming from experience, sometimes from solid knowledge, which have been learned.
Yeah.
But also at the end, if we think about system 1, sometimes it's needed because when like I'm teaching students the BBL, when we teach them about the case, sometimes there's things which you have to recognize from the beginning. It needs acute management for the patient.
Mm.
So if the student or the physician or whoever, if he will just rely on solid to get the reflection, and
Mm.
this may be also, affect the patient life. If
Yeah.
they don't have, if they will just wait until they see the whole, and
Mhm.
if they will not be able to recognize how much critical the case from the beginning, they will not
Yeah.
be able to interfere and provide the right and proper management for the patient
course
at the
you're
right time.
Well, you're right, certainly. And what I did not enough, what I did not have, I did not stress enough here this afternoon is the importance of practical experience, seeing many patients. So only part of what could be improved can be done in the medical school, but part of it has to be simply seeing many patients, many variations of the same disease, many new cases. Then you acquire a feeling of what is going on that sometimes is cannot even be verbalized,
Yeah.
but plays an important role in accurate decisions. And the best doctors sometimes say, yeah, I don't know how I got at this diagnosis, but it was there. Yeah, simply based on 30 years of experience.
Yeah.
And seeing and listening to patients and being aware of the signs, the little signs and symptoms that people display, and how people come into the consulting room, how they walk, how they talk, how they look. These are things that are difficult to verbalize, but they play an important role. But for me, that is also knowledge.
Yes.
Yeah.
Thank you. Any more questions? Dr. Ayhan, any more questions?
Actually, I have two questions, if I may.
Yeah, go ahead, please.
Thank you very much, Prof Henk, for your presentation. One question, you said that group learning is a way of learning clinical reasoning. During the PBL tutoring sessions, I have discovered that some knowledge coming from the students are not accurate, actually.
Yeah.
They think that this is the fact, but they are not sure, and nobody knows. So I see a danger here to misguide students in terms of clinical reasoning or making decisions. And what is your opinion about that? Also, I have seen an opportunity here to teach them clinical reasoning as they are functioning as a group. So how we can balance these, and how can you elaborate on this? Thank you very much.
Yeah, I don't know exactly how problem-based learning is conducted here, but if it's in a traditional way, the students are confronted with a problem for which they have only limited knowledge, and therefore wrong ideas and wrong convictions. But what you hope is that by self-study, many of these wrong convictions are repaired. And in a second discussion of the problem, students can also correct each other. So I've never been that worried about wrong ideas, because wrong ideas are also important. Of course, they need to be removed eventually, but if they are in the mind, there should be a confrontation between what you think and what others think, and etc. So I'm not that worried about it. And I'm speaking here not of problem-based type of activities like there's in your curriculum, but I'm speaking here on the end of a course on Friday afternoon or on Thursday afternoon, where students meet in small groups and get 15 problems relevant to what they have studied and work their way through in small groups with feedback of a supervisor or a teacher. That is my ideal format. And of course, you can also use digital means and etc. Yeah. Okay. Thank you very much for your attention. I'm very glad that you are here, because it's difficult to talk to a room where nobody is there.
Yeah.
and at least you were there, and I saw that 17 people were there online.
Yeah, we have like 23.
How many did you expect?
We have they registered for face-to-face 32 and for the online 36. This is just 30 minutes before, I check it 30 minutes before starting the event.
So a lot of people
They
had
miss
something
it.
more pressing
Yeah.
to do.
They miss it. Yeah.
Yeah, that's life. That's life.
Anyhow, we record this session and I will share it with all faculty, inshallah. So they will get benefit from this. Thank
Okay.
you, Prof. And thank you so much. This is Zek. Thank you. Thank you all.
Thank you. Okay. How do you see artificial intelligence, so clinical reasoning? Very helpful. Is it going to be